Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Effects of Education and Income on Treatment and Outcome in Acute Myeloid Leukemia Patients in a Tax-Supported Healthcare System, a national population-based cohort study by Osgaard et al. My name is Bill Wood, and I am an Associate Professor of Medicine at the University of North Carolina in Chapel Hill, North Carolina. My oncologic specialty is bone marrow transplantation and hematologic malignancies. Acute myeloid leukemia, or AML, is an aggressive and life-threatening hematologic malignancy. Some patients who are able to undergo intensive induction and consolidative treatments, including in some cases allogeneic hematopoietic cell transplantation, experience long-term survival. Others experience early treatment failure, relapse after initial remission, or early or late direct or indirect treatment-related complications that lead to death. Thus, the median duration of survival for the overall population of newly diagnosed patients with AML is limited. Some experience extended survival, while many do not. The chances for long-term survival are impacted by age, comorbidity, cytogenetic and molecular risk, type of treatment received from induction through consolidation, and the presence of treatment-related complications. Though 2017 has seen 3 new approvals by the United States Food and Drug Administration for AML treatments, the overall management of this disease has remained relatively unchanged for several decades. Improvements in outcomes have therefore resulted from refined risk stratification with appropriately tailored treatment strategies and improved supportive care to mitigate treatment-related morbidity and mortality. Against this background, Osgaard et al. Sought to determine whether individual-level socioeconomic factors influenced outcomes in AML, and whether potentially modifiable targets could be identified. The authors of this study investigated a unique and valuable population-level resource, the Danish National Acute Leukemia Registry, or DNLR, which contains prospectively collected high-quality data on greater than 99% of all adult Danish AML patients. This dataset is also unique in that it exists within the setting of a country whose population has free access to tax-supported healthcare. This includes access to diagnostics, treatments, and follow-up within the public healthcare system. No cancer treatment takes place in private hospitals. From a research perspective, this unique setting allows for the potential disentanglement of factors usually associated with inferior healthcare access in other settings, such as type of insurance or income level, from other socioeconomic factors that could plausibly have an association with disease outcomes. The authors were able to identify 3,495 patients diagnosed with non-promyelocytic AML between 2000 and 2014. Clinical and disease variables that were considered included AML karyotype, cytogenetic risk, complete blood count at diagnosis, presence of extramedullary disease, performance status, comorbidities, type of therapy received, inclusion in clinical trials, and receipt of allogeneic hematopoietic cell transplantation in first complete remission. In addition to age and sex, other patient-level variables that were available to the investigators included income, marital status, cohabitation status, employment status, and education. For the purposes of this analysis, education status was classified into low, or less than or equal to 9 years, medium, or 10 to 12 years, and high, or greater than 12 years. The authors performed several analyses to investigate the relationship of income and education with treatment and outcome in AML. Using logistic regression, the authors examined the association between education and income and receipt of intensive chemotherapy, as well as the association of these factors with the receipt of allogeneic transplant and first complete remission. The authors also examined the effects of education and income on overall survival using Cox proportional hazards regression models. When age was used in stratified analyses, an age cutoff of 60 was applied. In the final dataset, 2,992 patients with AML were included, of which 53% received intensive therapy. The median age at diagnosis was 68.5 years. The educational distribution was split into 45% of patients with a low education, 38% medium education, and 17% high education. The authors found that in younger patients, while receipt of intensive therapy was similar by education and income, receipt of allogeneic transplantation and first complete remission among those with unfavorable cytogenetics was higher in the high education group, 18.4%, than the low education group, of which 10.6% received a transplant. This difference was statistically significant. Among older patients, those with low education were less likely to receive intensive therapy in general. In the Cox models, 1-year survival for the overall population was higher in the high education group than the low education group, 65.2% versus 57.7%, and these differences persisted at 5 years, 36.8% versus 23.1%. The authors also analyzed only those patients who had received intensive therapy, a total of 1,588 patients, and stratified this analysis by age greater than or less than 60. In this analysis of only intensively treated patients, those less than the age of 60 with medium or low education had worse survival than those less than the age of 60 with high education. These differences remained after adjustment for age, sex, income, marital status, occupational level, and clinical factors including cytogenetic risk. Income was not associated with a survival difference in this younger age group, and neither income nor education was associated with a survival difference in patients over the age of 60 after adjustment for other relevant factors. Finally, the authors looked at survival over time. In this analysis, they found that in younger, intensively treated patients, 5-year survival improved in the high education group from 39% in the earliest years of analysis to 58% in the latest years of analysis. However, 5-year survival did not significantly improve over time in the medium and low education patient groups. So, what can we learn from the study? The authors' major findings were that younger patients with acute myeloid leukemia were more likely to receive allogeneic transplant if they were more highly educated, and that a higher level of education, but not income, was associated with better overall survival in younger patients with AML. Further, improvements in survival over time seem to be limited to the more highly educated cohort. Taken together, what does this tell us about the relationship of education with outcomes in AML, and where do we go from here? First, while the data source used in this study was a strength, this was a truly population-based study with a rich and complete set of patient, disease, and treatment-related variables. It also invites questions. Were there unique features of healthcare delivery in the Danish population that were associated with unmeasured variables linked to education? For example, were more highly educated individuals more likely to live in areas associated with differences in treatment or referral patterns for AML? On the other hand, while the effect of more traditional barriers to care access were lessened in the single-payer insurance environment, would these more traditional access barriers overshadow the effects of education in other settings? Second, if additional studies in other environments confirm the relationship of education with AML outcomes, what is the mechanism by which education exerts this effect? Are patients with higher levels of education more likely to be referred by their treating physicians for allogeneic transplant, or evaluated by transplanters as acceptable transplant candidates, or choose to undergo transplantation after being presented with transplant as a treatment option? Additionally, are patients with higher levels of education more likely to adhere to treatment or supportive care recommendations, whether within or outside the setting of transplantation? Additional studies will be needed to clarify the mechanism by which education is linked to outcome, so that targeted strategies can be devised to improve outcomes in the less educated cohorts. These types of studies, to confirm the author's findings and to understand the mechanism by which they occurred, are urgently needed. As this study and many others in other countries illustrate, allogeneic transplantation is significantly underutilized among potentially eligible patients with AML across all educational categories. As additional high technology and high risk therapies are developed that require careful care coordination at many points along the delivery continuum, such as CAR T cells for ALL, NHL, and possibly other diseases soon, causes of underlying disparities in access to these therapies must be better understood if as many people as possible are to derive benefit from them. In that sense, then, the study by Osgaard et al. Is a call to action, and our patients will be well served if we respond in kind. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.